sir, and you will be connecting for next 10 minutes. And by then it will be around 3:25. And if the time permits, then we will take some questions by the viewers, which will be coming online on a chat box to me. Um,
Fine,
how,
that's great. That
yeah.
sounds nice.
Dr. Leisure, how comfortable are you if it gets extended by just couple of minutes? Is that okay?
That's fine. No, I've had my dinner. I'm at your disposal for as long as you wish.
Oh, that's so nice of you. Thank you so much. Just maybe it may get extended by a couple of minutes, not more than 5 minutes maximum.
And it actually demonstrates that the audience are interested, which is a good thing.
Yeah. So we have been doing this webinar on a monthly basis. In a month, one we do, and we have been getting good response. Actually, near about 1,500 doctors all over the India do, either from their clinic or from their residence or from their hospital. The most comfortable and most convenient way of now educating doctors.
Isn't it? No, it's by far the best way to reach out to a lot of people without them having to travel.
Yeah.
They just take it out of their day. No, it works very well.
Sorry to interrupt all. Dr. Swati,
yeah.
We are live right now.
Yes. We are starting.
It's all yours.
Okay. Very good afternoon to all of you. Thanks for joining for this Empower webinar series. I am Dr. Swati Naik. I'm the head of medical at MK Pharmaceuticals Limited. And it gives me a great pleasure to welcome each and every one of you for today's webinar on the topic of endometriosis and infertility. And we are pleased to have with us Dr. Professor William Leger, who joins us from Australia. Thank you so much, sir, for joining us. Today's webinar, we also have with us Dr. Shanta Kumari, who joins us from Hyderabad, and we have with us Dr. Amit Patki, who joins us from Mumbai. Thanks to both the panelists for joining us. And this is a very important webinar because we know that endometriosis is really an enigma to all of us, to the clinicians, and there is a lot to research in endometriosis and treatment. So before I go on to the actual lecture series, I would like to do the quick introduction of all of our three faculties. Dr. Professor William Leger is the head of discipline of obstetrics and gynecology of the Faculty of Medicine at the University of New South Wales. He is a director of reproductive medicine and senior staff specialist at Royal Hospital for Women and chair of the research and development committee and fertility specialist at IVF in Australia. Before moving to Sydney in 2011, he was a professor of obstetrics and gynecology at the University of Sheffield from 1999, before which he was a reader in obstetrics and gynecology at University of Oxford. He is an editor for reproductive endocrinology for reproductive biomedicine online and a member of editorial board of 8 scientific journals. His research interests focus on in vitro fertilization and assisted reproduction, impacts of reproductive aging and disorders such as endometriosis, premature ovarian failure, and PCOS on infertility and quality of life, reproductive effects of cancer treatment and health economics and demographic aspects of infertility. He has published over 270 peer-reviewed research papers and edited 13 books on aspects of reproductive medicine. So thank you so much for joining us for today's webinar. Your lecture is going to be really most important for us in terms of understanding endometriosis and infertility and most therapeutic options. We have with us Dr. Shanta Kumari, who joins us as a panelist from Hyderabad. She's a senior most consultant and laparoscopic surgeon from Yashoda Hospital. She's been a secretary of ICOG during the tenure 2015 to 18. She's a chairperson of ICOG 2018, and a conference is coming up in the next month. And she has been a vice president of FOXI in 2013. She's a member of FIGO working group on violence against women. She's just returned back from Rio FIGO conference, and she has given a talk on violence against women, as well as she has done I think it was a very appreciated talk on this very important topic. Thanks, ma'am, for joining us on this webinar. And we have with us Dr. Amit Patki joining us from Mumbai. He is a senior consultant and obstetrician gynecologist and infertility specialist. He's the honorary secretary of General ESAR and medical director of Fertility Associates Mumbai. Thank you so much, Dr. Amit Patki, sir, for joining us for this webinar. With this brief introduction, ladies and gentlemen, let's hear from Dr. Professor William Leger on today's topic. Over to you, sir.
Excellent. So I hope that you're all able to see the PowerPoint, and good evening, good afternoon. Good evening from Sydney, where it's now 8 o'clock at night. So a very good time for me to talk to you about one of my favorite topics, which is the impact of endometriosis on fertility and how best to address this problem with our patients. Thank you at the outset to MCure for organizing this. It's a very good way of spreading information amongst a large number of people without eating too much into their working day. And I'm very proud and privileged to be part of the program. Having seen some of your previous speakers and those who are coming along shortly, I do recommend this program as a whole. It has an excellent faculty. And it's interesting hearing about FIGO, because the next FIGO meeting in 2021 is here in Sydney in Australia. I'm part of the organizing committee, and I would love to welcome one and all of you to Sydney, one of the world's great cities, at a time of the year when we're just into the summer, so it's beautiful weather, not quite as hot as it is in Mumbai or Hyderabad. So just in terms of giving structure to the talk, I've decided to base this on the guidelines from the National Institute for Health and Care Excellence, the institution we know as NICE, based in the UK, but they create guidelines that I think are globally relevant, and they use very rigorous processes to assess evidence and make the best recommendations according to that evidence. And if you log on to the NICE website, the picture you see in front of you is their home screen, the front page. And you can click on the purple box to look at NICE guidance for whatever topic you wish to review. So if we click on that box, one of the first topics they reviewed way back in 2004, their 11th clinical guideline, was called fertility, assessment and treatment for people with fertility problems. And this area of medicine is seen as so important that NICE then updated and reviewed this in 2013 and gave us a new series of guidelines that we'll explore with relation to endometriosis. Not only that, but you can also see this guideline, endometriosis, diagnosis and management, which came out only 1 year ago, so it's very current. And that looks at the whole picture of endometriosis, the management of pain, other clinical problems, how best to address them. And there is a section on fertility, as you can see from the links. So we can approach this through the National Institute for Health and Care Excellence from two different aspects. So to begin with, because there's still a lot of good sense and good knowledge here, let's just briefly review what the 2004 guidelines said to us about the management of endometriosis associated with infertility. And you'll notice their phraseology, endometriosis associated with infertility. They don't imply causation, and that's a topic which is still of relevance today, and we'll touch on that a little later. So it's a little difficult for me because can you manage to move the pictures of myself and my colleagues to the side on my screen, because they're getting in the way? Is that possible to do? Possibly not. Let me try and do that. No. That's better. Okay. So the first topic is medical treatment of minimal and mild endometriosis does not enhance fertility in subfertile women and should not be offered. And in 2004, they gave it a grade A evidence. I've frozen, hold on. That's better. Women with moderate or severe endometriosis should be offered surgical treatment. And also women with minimal or mild endometriosis who have a laparoscopy should be given surgical ablation or resection of endometriosis plus laparoscopic adhesiolysis, because it improves the chances of pregnancy. Grade A evidence in minimal and mild endometriosis, and grade B evidence in moderate or severe. And then finally, do not give post-operative medical treatment. In those days, mostly it was with Zoladex, because it doesn't improve pregnancy rates in women with moderate or severe endometriosis and delays the return to ovulation and fertility. So not recommended to combine medical and surgical treatment. If there's an endometrioma, offer laparoscopic cystectomy, because this improves chance of pregnancy, a grade A evidence. And with regard to intrauterine insemination in 2004, couples should be informed that ovarian stimulation increases pregnancy rates compared with no treatment. So use of gonadotropins is recommended, but combining that with unstimulated IUI is uncertain. And despite that uncertainty, they gave that recommendation a grade A again. So equivocation about the role of stimulated or unstimulated IUI. But they went on to suggest that couples with minimal or mild endometriosis should be offered up to 6 cycles of stimulated IUI because it increased the chance of pregnancy. One of the areas that was updated and reviewed in 2016 was the revised guidance on IUI. And this caused great controversy in the UK, in Australia, and I think around the world, because new evidence from studies that one might regard as a bit substandard suggested that IUI with or without ovarian stimulation was not effective, and people were advised to try to conceive without help for up to 2 years and then move straight to IVF, omitting what many of us would regard as the middle road, which is to do IUI for a few stimulated cycles before IVF. So, and this might be something for the discussion, and we'll come back to it later. The recommendation about IUI was revised in 2016 and basically taken off the agenda by NICE. The problem for me this evening is I'm trying to look for guidance from NICE about how to do endometriosis, how to manage patients with endometriosis in the IVF world. And there are no guidelines whatsoever in any of these guidelines about what to do with patients with endometriosis. So we have to leave the NICE guidance behind and go off-piste and see what we can find for ourselves. So I guess the first question is the one about causation. Do we believe that endometriosis actually causes infertility? And I think the answer is probably yes. And you can use evidence like this from my friend from Bristol, Dr. Valentina Kande. And what you see in front of you are curves for pregnancy and live birth over time in years. And the dotted line is for women with minor endometriosis, and the top line for women with and couples with unexplained infertility. And you can see that both for pregnancy on the left here and live birth on the right, having even minor endometriosis reduced the chance of conception over a 3-year period compared with unexplained infertility, suggesting that endometriosis has an adverse effect on chances of natural conception, even when mild and moderate. And I think many of you would agree with the suggestion that severe endometriosis almost certainly does cause infertility, if nothing else, but because of an anatomic problem that you can see in this case. The fallopian tube is here lateral to the cyst, and the healthy ovary is medial to the cyst. So the chance of an ovulation from this ovary allowing the egg to hit the tube and travel to the uterus is presumably reduced in comparison with a healthy pelvis. That leaves aside the ongoing debate and argument about whether endometriosis fluid and cytokines and such like produced from that are toxic to the egg. I think that's still a debate which is going on. But just the anatomic disruption and also the dyspareunia, which means that women with severe endometriosis often don't have frequent sexual intercourse, must cause some kind of a impairment of the chance of pregnancy in this group. So then the next question is, and the topic of this evening's talk really is, what are we going to do about it? And I predicate this to say that this evening is not about endometriosis-related pain. Women with pain who also have a fertility problem are more likely to go the surgical route because it's a way of trying to resolve 2 problems at the same time. So we're looking at women who don't have a severe problem with pelvic pain with endometriosis, but do have a fertility-related problem. So the Cochrane database, medical treatment of endometriosis to treat infertility is probably worthless, and this was the basis for the NICE guideline. Again, you'll notice this is very old data, and there really are not any recent randomized studies comparing medical suppression of ovulation with many newer agents with placebo. But the conclusion from 2003 was that there was no benefit, no increase in the likelihood of pregnancy if you gave 6 months or 12 months of ovarian suppression. But I would point out that these were the studies that this was based on. This is one from Eric Thomas, who was working in Sheffield at the time, back in the 1980s. Very small numbers of patients, 16 versus 20, treated versus untreated, followed up in 12 months, showing that there was no benefit of downregulation with gestrinone or progestogen in this group. And I do think that it's time that these studies were done again and done better with modern drugs and modern adjuvant treatments to enhance fertility at the end of the period of suppression. And it may be that this evidence is now out of date. And I know, for example, that recently in India was the launch of Visan, which is Dynagest, which is a good progestogen for suppressing endometriosis pain, preventing the chance of recurrence of endometriosis cysts, and helping women with dyspareunia. And it might be that these kind of new agents need to be reassessed, and then maybe a role for them in the management of subfertility. Surgical ablation, however, does seem to help. And again, old data, not being repeated in the last 20 years. This is from the Canadian EndoCan study that was published in 1997, along with less well-designed cohort studies, but all of which showed that surgery, even to minimal or mild endometriosis, went on to improve the chance of a natural conception in women with infertility. This study was published in the New England Journal of Medicine, very high impact, and it went around the world and encouraged those of us who do laparoscopic surgery to continue laparoscoping women with mild or moderate endometriosis to treat their infertility. Here's the survival curve for weeks after randomization. And you can see that over 36 weeks, sorry, just give me one moment. The chance of conception after surgery compared with diagnosis was about double. Let me grab a glass of water. That's better. Right, sorry about that. So the chance of pregnancy after the surgery was practically doubled. Problem was the only other study around at the time was this Italian study, which was complicated and less well designed, and basically showed no improvement in the chance of a pregnancy with treatment compared with no treatment, no improvement in the chance of a live birth at term in the two groups. So controversy, but when the meta-analysis was done, the Canadian study was so much bigger and better that it prevailed. And I think this is a conclusion for today, that there is improvement in pregnancy rates after ablation of minimal and mild endometriosis. The problem in 2018 is that we do not use the laparoscope as frequently as in the past for women with infertility, because ultrasound has become so much more reliable and powerful that the days when every woman with a year or so's infertility had a laparoscopy are gone. So there are cases where this is undiagnosed and therefore untreated, and it may be time to revise. There are new biomarkers in the circulation for endometriosis that are looking very promising. So if we have a non-invasive diagnostic for endometriosis, we could then target treatment at the appropriate patients. So treatment for severe endometriosis with surgery and infertility is recommended, but the question is, how should we do it? The NICE guideline 2017 on endometriosis diagnosis and management has these guidelines. Offer excision or ablation of endometriosis, plus do adhesiolysis if the bowel is not involved, because it improves the chance of spontaneous pregnancy. So your preference as to whether you like to excise, which is what we do in Sydney, or ablate endometriosis in these mild or minimal cases. An ovarian cyst should be excised laparoscopically with excision of the cyst wall, but they do draw attention to the impact on ovarian reserve, and we rely on measurement of AMH before and after ovarian cystectomy, and frequently we'll see a significant diminution in AMH after the surgery as a consequence of damaging the healthy ovarian cortex while stripping the ovarian cyst wall. And I think from our own experience, in some cases it's very easy to strip out the cyst wall, in others it's more adherent and tends not to detach well, and in those cases we leave it alone and apply diathermy to the inside of the cyst as an alternative. It's about case selection. The women with deep endometriosis are more complex. This requires discussion with the patient, and she and maybe her partner have to be involved in making choices, because the surgery itself may lead to adhesion formation and damage to anatomy, which may impact on future pregnancy. There might be severe impact on ovarian reserve in a difficult case with big endometriomas. The impact of complications such as the problem of inadvertent damage to bowel leading to adhesions and peritonitis, and alternatives to surgery, for example, using an IVF. So these discussions are complex but worth having, and a lot of women will opt for surgery, particularly if they also have pain. This is our own series we published in 2015, looking at the surgical treatment of severe endometriosis and its impact on the chance of natural or assisted conception pregnancy after surgery. So this is a single center study from our own unit in Sydney. We identified a total of 375 women who'd had surgery in our center for stage 3 or 4 endometriosis. Of those, we managed to find 253 patients who were willing to participate, which meant us contacting them and looking at their future pregnancies in the years after the surgery. And we had quite a long follow-up period in our center. I think the important thing was that we have a systematic approach to the surgery. So all of these cases were addressed in the same way. In Sydney, we relied heavily still on Veress needle entry. If there's been previous surgery or suspicion of pelvic adhesions or abdominal adhesions, we'd use an open entry technique. A full visual inspection of the whole abdomen and pelvis with adhesiolysis and breaking down any abnormalities in anatomy as much as possible. Resection of lesions with monopolar scissors rather than diathermy using retroperitoneal approach. Where possible, stripping endometriomas with the aim of removing all visible endometriosis, and dissection of deeply invasive endometriosis in the pouch of Douglas using sharp dissection with the help of a bowel surgeon who would perform segmental bowel resection if necessary, again with the aim of completely removing endometriosis, so a fairly radical approach. But the results were quite startlingly good, and you can see in blue for assisted conception after the surgery, or in red, the natural conception, and the breakdown is about 50-50 in the women who went one of these two roads. Whichever route they followed, following the surgery to endometriosis, within a reasonable number of months, about 70% in both groups had had at least one conception, and most had at least one live birth. Half of them with no intervention apart from the surgery. So yes, it's a single center study and it was not randomized, but I think this kind of work from around the world is quite powerful when showing that surgery has a place. So let's move on to the topic of assisted conception in the patient with endometriosis and this reaction to the NICE guidance saying we should not offer IUI to couples with minimal or mild endometriosis, which I think a lot of us felt was somewhat misguided. So there were several studies published recently in reaction to this, and this is a NICE series from the south of England that looked retrospectively at almost 851 couples and almost 1,700 cycles of women who had at least one cycle of IUI with gonadotrophin stimulation in this study period and went on to complete up to 3 cycles if there was not pregnancy. The patients involved were not particularly young, with a mean age of nearly 34 years. They'd had a reasonably long duration of subfertility, so these were not easy cases by and large. But with IUI, with controlled ovarian hyperstimulation over 3 cycles, they achieved a live birth rate, not a pregnancy rate, of nearly 35% and a multiple birth rate of only 5% because of judicious use of low-dose gonadotrophins and cancellation of cycles where they saw high-order multiple follicular development. And the women who did the best, unsurprisingly, were those who were younger and those who'd previously had a pregnancy and a live birth. So with that kind of evidence, NICE has again revised its guidelines and is now saying that maybe we should offer IUI as a cost-effective and most importantly, a acceptable to patient alternative to IVF, because as you well know, it's much cheaper and much less stressful and complex for women to do compared with IVF, and the issue of accessibility is very important around the world. So personally, I think there is still a place for IUI as a middle ground, maybe after the surgery or after the diagnosis, but before IVF. So then moving on to looking at the role of IVF for women with endometriosis, and we all dread seeing this kind of picture when we're doing the workup for a patient for IVF, because it means there's going to be delay while that endometrioma is dealt with. And there have been many publications talking about which size of endometrioma we should think about is worth resecting surgically and which size is best to leave alone. Clearly, if the endometrioma is very small, and especially if the patient has no pain and is not keen on surgery, it's best left alone. If the endometrioma is very large and there is associated pain, it's best resected. And of course, in the real world of medicine, most patients fall in the middle between those two groups. One thing that seems to me is useful is if you can see most of the ovarian tissue at a distance from the tip of the vaginal probe, which is where the egg collection needle is going to go, with the endometrioma lying between you and the bulk of the ovarian tissue, it's probably worth resecting. And it's not usually wise just to drain these because they recur quickly and there's a chance of inoculating the cyst with infection, and so problems can arise. So a proper laparoscopic resection is probably the right way to go for most of these cases, where the cyst is maybe larger than 3 or 4 centimeters in diameter and is impinging on your ability to collect eggs. It's difficult because IVF is very costly and the woman wants to maximize her chances of pregnancy from 1 or 2 goes at IVF. And so given the endometrioma is there, it's always tempting, isn't it, to do the laparoscopic surgery and tidy it up. And often I think that's the best approach. The problem, as I say, is diminution of ovarian reserve. And if someone already has a low AMH or is a bit older, it might be worthwhile in a moderately sized endometrioma leaving it alone, doing at least 1 stimulation cycle. And if it doesn't go well, plan B, if there's not a pregnancy and the egg yield is low, is to go ahead and do the endometriosis surgery and then do another IVF later. So it really is about individual case selection, and there's no hard and fast rules about how we ought to address this. So this is from my good friend Ying Chong, who's the professor now in Southampton in the UK, and they performed a very large systematic review asking the question, does endometriosis impair the outcome of IVF? And the findings, I think, are quite valuable just because the number of patients and studies included is large. So what you see here is that compared with women without endometriosis undergoing IVF with or without ICSI, those women with endometriosis had a similar live birth rate, age adjusted, looking at over 12,000 patients in 13 studies. The odds ratio for a patient with endometriosis having a successful outcome from IVF compared with a woman without endometriosis is 0.94, with a 95% confidence interval well crossing unity. So endometriosis itself does not seem to have a big impact on the outcome of IVF. In terms of live birth, lower clinical pregnancy rate, high number of patients, the odds ratio just doesn't quite make it to unity. So again, if there is an effect, it's quite small. But more definitely a lower yield of oocytes, which we've discussed, the impact on the cortex of the endometriosis and possibly surgery, and no increased risk of miscarriage in women with endometriosis after IVF compared with those without. So quite reassuring data that this group are not, as a whole, hugely impaired compared with other women undergoing IVF. But the key thing that those with more severe disease, categories 3 and 4 from the ASRM categorization, all had a lower live birth rate, clinical pregnancy rate, and mean number of eggs. And these numbers were more severe than those with mild or moderate endometriosis. So those cases with severe endometriosis need to be dealt with in a center that has specialist interest. The surgery needs to be done carefully and well to avoid unnecessary damage to ovarian reserve. And they're difficult cases who will give you lower number of eggs than that you would expect from a woman of similar age. So why is that? Well, this is a study from Claude Chaperon in Paris, very large center dealing with severe endometriosis. And they found that a history of surgery for endometriosis, for endometrioma, is associated with a poor response to hyperstimulation in a subsequent IVF cycle. This is their study. They began looking at 4,500 of their patients, again in a single center, treated from 2012 to 2015. 900 had endometriosis. 3,500 did not have endometriosis. All of them underwent an IVF cycle at least once. Those with endometrioma, they call it OMA, 367. And they were able to collect data from those doing IVF from 200 of those, compared with 1,400 of those without endometriosis, age and AMH matched. And those are the 2 study groups that they looked at. And their findings were quite interesting and informative because they see, as you might expect, a lower number of oocytes compared with the control group, but not a huge diminution. That led to a lower number of blastocysts, 1.7 versus 2.1. Again, not a huge diminution. And a significantly lower live birth rate in their center, comparing 26% with 30% in the women who did not have an endometrioma, with a similar miscarriage rate. So what we can conclude from here, firstly, is again that having endometriosis does not appear to have an impact on miscarriage, but a slight but significant reduction in live birth rate if there's surgery to an endometrioma, so by definition, moderate or severe disease, because those women suffer from a diminished ovarian reserve, lower egg yield, notwithstanding quality, compared with those of a similar age who didn't have endometriosis. So the same point that surgery has to be done judiciously and at the right time with the right patient selection. Does it actually improve the outcome to resect an endometrioma? Well, there are advantages and disadvantages. We find it easier in the world of IVF to monitor follicle growth. Having resected the endometrioma, it doesn't get in the way. It certainly makes the egg collection easier, but someone who's skilled at egg collection can often work around the cyst without damaging it. You won't have an infection from contamination of the chocolate cyst fluid with bacteria if you remove the cyst before you do the egg collection, and maybe success is improved. But of course, there's a cost associated with the surgery, and it may do harm to ovarian reserve, doing greater damage than good, at least in some cases. You can just look at this graphically. With age, we know that the ovarian response to ovarian stimulation declines as the primordial follicle number declines. And you can see this if you measure AMH or antral follicle count, you see this decline from age 25 going down to age 40. If you have endometriosis and it's affecting the ovaries, that will have an increased effect on the egg reserve compared with women without endometriosis. And if you treat that surgically, you may decline even further, leading to a serious loss of ovarian reserve in women, particularly getting to age 30 and older compared with the young. So it is a decision to make on a case-by-case basis. In Australia, we accredit our surgeons very carefully. We have two organizations that are relevant here and that are involved in the accreditation of clinicians specializing in reproductive infertility, in reproductive endocrinology and fertility, and also in endoscopic surgery. So the CREI is an accreditation in reproductive endocrinology. So those who want to specialize in fertility medicine at high level will have that accreditation. And part of it is surgical skills training and assessment. So they're all trained to do laparoscopic surgery to high level if they have that qualification. And many will get the accreditation from AGES, which is the Australian Gynecological Endoscopy and Surgery Society, which specializes in high level training, mentoring, and ensuring that people are properly assessed before they go and do this quite tricky surgery for level 3 and 4 endometriosis, often involving multiple surgeons with a colorectal surgeon, a urologist maybe for ureteric involvement, along with the gynecologist. And by doing that, we're training people to be conservative and try and avoid damaging the ovary as much as possible, compared with those who don't have the specialist training in fertility, who often use more diathermy, more cutting, damage the ovary more. And so they might get resolution of pain, but leave the person with a diminished ovarian reserve, with more adhesions, with more surgical collateral damage, which then leaves them less fertile than you'd like them to be. And going back to the series that I showed you that we published a couple of years ago in 2015, all the surgeons involved were accredited by one or mostly both of these bodies. So we could say that the surgery was done to a high standard. So then finally, what about the use of drugs in IVF? And my reading of this is it doesn't really matter if you use an antagonist or a standard long down regulation protocol. The outcomes for women with endometriosis are pretty similar. But there's an argument that we should use an ultra-long agonist protocol because by downregulating completely for at least 6 weeks, probably more likely 3 months, you suppress the inflammatory component of the endometriosis, reducing secretion of what you might call toxic molecules like prostaglandins, cytokines, cleaning the blackboard before you start to write on it with gonadotropins to induce follicle growth. And again, some years ago, I published with my good friend Hassan Salam, Cochrane review that looked at the use of ultra-long pituitary downregulation for between 3 and 6 months prior to ovarian stimulation, comparing these approaches for women with endometriosis with the standard long protocol day 21 start. And we found in all 3 studies, none of them particularly good quality, a significant impact and quite a high odds ratio for clinical pregnancy and a very high odds ratio for live birth, but from only one study, if you use long downregulation for 3 to 6 months compared with long protocol. Yet again, there's a shortage of more modern studies in this era, and many people have moved away from the delay in IVF that's imposed with 3 to 6 months of downregulation, and they would do either a long protocol or a short ANTAG protocol. But certainly in selected cases, if those approaches are not working, I still think it's worth trying a long downregulation for 6 weeks or 3 months before you stimulate. I think if you do that, it's probably important to use a gonadotrophin that has both LH and FSH activity because of the profound pituitary downregulation that you see with these long-acting GnRH agonists. One of the few areas where you really need to add back LH in ovarian stimulation, in my view. But if you do that, you may find a better outcome for women with moderate to severe endometriosis. So in conclusion, I think it's fair to say that even in 2018, this association between endometriosis and infertility still has more questions than answers. There are not many adequately powered and well-designed RCTs. All of you who are surgeons will know how hard it is to perform an RCT in a surgical setting, and that's why these studies are so few in number. So we don't have category A evidence for many of the things we do. I think in the real world, all guidelines, NICE, ASRM, ESHRE, are more simple than the patients tend to be. And in real world medicine, the guidelines can be helpful, but they're only guidelines, they're not mandatory. Patients will express their own preferences. And we all know that having a dialogue with the patient, with a partner, will often help us to choose the right pathway to navigate someone through their endometriosis problem and help them to have their family in an expeditious way, as cheaply and as less stressfully as possible. And I think with that, we should conclude. And I say thank you from the University of New South Wales in Sydney. That's our main campus. And I'd invite any of you who would like to come to FIGO 2021 and spend some time with us and maybe come and see some surgery and some ART in our centre. So thank you for your time and for your attendance.
Thank you, Professor William Ledger. That was a very interesting lecture. Very clear message. I think there was a lot of dilemmas about whether to use medical management or surgical management in managing infertility with endometriosis.
Correct.
I think message is loud and clear that surgery is definitely the most required management for infertility with endometriosis. But I would like to ask you one thing.
Yeah.
In women who have reduced AMH, would you advise a surgery as a first line of treatment?
Madam, I think if it was you or I doing the surgery, yes. But it needs someone who is skilled in fertility surgery, who is going to be very careful with the remaining ovarian reserve. Yeah. So if there is a large endometrioma and diminished ovarian reserve, I think it's important to resect it before IVF. But if the endometrioma is small, or if someone doesn't have the really good level surgical skills, IVF is a reasonable alternative in that group. So it's not cut and dried. If the AMH is very low, probably would try an IVF first if the cyst isn't too big. If the AMH is between 6 and 10 picomoles, I would do the surgery and then see what happens next.
Quite often nowadays, because vitrification is so good and simple, it is an option to actually get as many oocytes out, and you can cryopreserve the embryos, then treat her for endometriosis if it's an issue, and then go ahead. But the key message is, as Prof has very rightly said, is that the first surgery is always the best surgery, and going back in and out of the patient actually doesn't give them a good outcome. And so the first time is always the best time. So I think that is something we as doctors should realize and know, that if you do not have the expertise, I think it's better to refer them to somebody who's an expert for infertility related endoscopic surgery. Because quite often, with due respect to endoscopic surgeons, they can be sometimes very, very aggressive and try and remove, and in the process doing more harm than good to the patient.
No, I completely agree. And I think the days of the diagnostic laparoscopy should be over. Yeah. That you should only do a diagnostic laparoscopy if you're competent to deal with the situation that you encounter. Because no one can argue that having 2 anesthesias and 2 surgeries within 3 months of each other is a good thing for that patient. You know, there are always risks, things go wrong. As you rightly say, the first surgical approach is the time to try and fix the problem as best you can. And I agree that in some cases you will do an egg collection first, vitrify oocytes or embryos, and then go back and fix the surgery, and then maybe do another IVF later. There's all kinds of ways of managing these cases individually.
Yeah. And there was one more recommendation which Professor William has mentioned, that post-operative management after your first surgery of endometriosis, not to use GnRH agonists or any other these newer progestins. So that's I think, a statement which many people would still refute, because now we find a lot of gynecologists using post-operative medical treatment after the surgical correction.
Yeah, but having said that, if it's worth putting them on three months of GnRH, long GnRH agonist, if you're planning to go for an IVF, because that really helps you to get good egg quality.
So take the two scenarios, because what our own series shows is that half of our women who had the surgery then tried naturally for pregnancy and conceived quickly. So if they're wanting natural conception, try and encourage them to try as quickly as possible, because that's when the maximum benefit from the surgery. We do try and ask them not to have intercourse in the hospital, wait till they get home, but try quickly, yes? However, you're right. If they choose to go the IVF pathway, then downregulating just to let them recover from the surgery for a couple of months straight into a stimulation without never having ovulated, without never stimulated the endometriosis, is an alternative route. And that requires planning before the surgery, doesn't it, to work out how they're going to go afterwards as the surgery is set on the road. And so that's a very good alternative if they want to do IVF. There's no point letting the endometriosis come back.
I just wanted your take on, there are lots of patients who do not prefer to go on the gonadotropin IUI route, would like to go on the clomiphene or letrozole route, especially in endometriosis. What is your take on that?
Well, I think the evidence is that the gonadotropin route has a slightly higher pregnancy rate per cycle than the oral route with Clomid or letrozole. But Clomid and letrozole IUI is better than unstimulated IUI.
Absolutely.
So you're absolutely right. It depends on the local situation, the cost, the availability. I think if you're using gonadotropins, you must have good ultrasound, because the risk of a multiple pregnancy higher than twin is significant.
True.
Whereas particularly with letrozole, the risk of a high order multiple is really low. So for a clinic that doesn't have reliable ultrasound 24/7, there's no reason not to use a letrozole IUI. Cheaper, and you may need one or two more cycles to achieve the same pregnancy rate with that route, but better than that than unstimulated.
I also had a question to you, Prof. We know that the overall success, even in IVF in patients with endometriosis, is lower than any other cause for IVF. Is it something to do with the egg quality? Although you may find that sometimes the AMH levels are normal, or is it something to do with the Hox gene that their implantation is basically low, even if the uterus is not affected? Is it something to do with immunology? Because I strongly suspect that when you give them this long GnRH agonist, I think you are trying to even, in a way, suppressing their, doing some immunomodulating them to accept the pregnancy. So I just wanted to have your take on this.
I know it's a really interesting question, and we're looking right now after 3 months of pituitary downregulation at the endometrial genome, and it's totally different if you then give back estrogen and then a bit of progestogen and do the biopsy and send it to the ERA. If you downregulate for 3 months, it alters the expression of genes, and you may well be right that you get a better quality endometrium, more likely to implant. However, if you look at studies where they've used donor egg embryos in women with severe endometriosis, the implantation is good.
Very good.
So I don't think there's a radical effect on the endometrium of having an endometriosis in the pelvis. Different if there's adenomyosis, and of course there often is, and we're not great at diagnosing that, so that can cause a uterine effect. Right? And again, I'm not convinced that egg quality is affected in a significant way by having an endometrioma adjacent to the follicle in a young person. But maybe if the woman is older, the effect becomes more pronounced. So a 40-year-old with endometriosis has less good quality eggs than a 40-year-old without. But someone who's between 25 and 30, I don't think it makes much of a difference. So there's a complexity. And also someone that has mild or minimal endometriosis, less likely to have an egg quality effect someone with a grade 3 or grade 4. So not an easy one to answer, but I do think this approach of long down regulation for 3 months and then artificially stimulating growth of endometrium might be something well, we're looking at it with the ERA, and I'll let you know in due course whether we find it's beneficial.
Lovely, lovely.
Ma'am, do you have any further question?
I think there has been a lot of clarity in what Professor shared with us. Does any of our viewers have any questions which they would like to ask Professor William?
Yeah, there's one question I mean, we are getting a lot of good comments for an excellent lecture from all the viewers. Most of them have asked for your email ID as well to communicate to you. Okay, there's one question coming up.
I have a PA that screens them all, so she can read them all. That's absolutely fine. Yes.
Yeah. So there's one question coming up. They want to know how to improve the quality of life in patients with endometriosis and infertility, because there is a lot of psychological disturbance in endometriosis patient and an infertility on top of it.
Yeah. Yes. That's a very good question and a very important one, because in a way, the poor patient has a double burden, because it impacts on a sense of well-being. If someone knows that she has endometriosis, people feel that this is harming their fertility, harming their uterus, harming their ovaries over time, and add on to that a problem of infertility, which can be profoundly depressing to people. It's a double whammy, if you like. And so the way to improve best you can is, firstly, we use a multidisciplinary approach. We have great counselors and psychologists that work with us, so they get involved. Often it helps you to choose a surgical route, because if the patient knows that you've had good surgery and the endometriosis is dealt with, psychologically she's in a better place. And then the best way of all is to give her a child, because a woman who's had the child that she so desperately desires almost certainly will have a better quality of life than someone who's struggling with infertility. So using appropriate resort to IUI, as we've spoken about, to IVF, and not delaying too long. There's a sense in some parts of the Western world that we should ask these patients to wait at least 2 years before an IVF. And personally, I don't agree with that, because by the time they've presented, they know they have a fertility problem. They've often tried 6 months, 12 months. They know something's wrong, and they wanted some treatment, and their partner wants treatment because he wants to be a father at the same time. So taking this ultra conservative approach, taking that point in mind about the well-being and quality of life, no, I think patients deserve some treatment, even if it's only doing a test of tubes and an IUI, which doesn't have a huge pregnancy rate per cycle, but they know that something active is being done.
Absolutely, sir. Thank you so much. Definitely a multidisciplinary approach, and a good amount of counseling and spending some good amount of time with patient would really help in such cases. There is another question coming up, a very common duo, that is endometriosis and adenomyosis. It is together in any one patient. What would be your priority to treat?
Well, again, we have two expert colleagues online with me, and I value their
answer after you. They could also add to it, or they could also answer. That's fine.
I know, because this is a very difficult conundrum. Focal adenomyosis can be surgically resected, and it shows up very well on MRI with a T2 weighted image. You can use that if you wish, as well as ultrasound, to really define the lesion before you go to surgically resect it. But most women have a diffuse adenomyosis, and that's not resectable except with hysterectomy, which is obviously not the appropriate approach. So again, we go back to medical management, downregulation, GnRH analog. Maybe one of the newer agents like Dynagest would work just as well as it does in pain. So there's a number of oral medications now as well as injectables. And we're seeing the launch of an oral gonadotrophin release hormone agonist as well. So there are new things around in the medical management arena. So for me, answering that question, probably 3 to 6 months of some way of suppressing the endometriosis in the uterus, so the adenomyosis, and then go straight to IVF is probably the best chance of a baby. But there's no RCT evidence on that, and it is a difficult case.
Ma'am, would you like to add anything?
Experts?
I think Professor Williams has very rightly put it. Maybe nowadays the latest progestins like Dynagest and all have been, some studies have quoted that they do help when you have an associated adenomyosis with endometriosis. And there are some studies which show some studies have said that the focal resection of adenomyosis and later the chance of conception is good. but there are some contradictory studies also that it may not be very useful. So it's a very tricky and a dicey situation, and you have to individualize the patients.
Agree.
Sir, would you like to add anything to that?
No, I fully agree with the two other experts that I think I would believe debulking the uterus if it's a focal lesion. And I think down regulation by whichever method is going to really help us. And as a prof said, I was there at the ASRM when I realized that it's an oral GnRH one is soon going to come into the market, and I think that may help us for long-term treatment instead of being on the injections or something like that. But down regulation will help. Prognosis is poor when there is diffuse adenomyosis, especially the uterus size is more than 12 or 14 weeks of pregnancy.
Correct, yeah. Ma'am, there's another question like, so you talked about that if the cyst is big, endometrial cyst or the endometrio is big, one need to go and do the surgical management. So what is that size of the cyst that you suggest that they should, go for the surgery?
I know it's easy. You start at the extremes and work towards the middle. So someone who has a 7 or 8 centimeter endometrioma, particularly as often happens, they have those cysts in both ovaries. That's going to make an IVF egg collection very difficult and will probably impair the ovarian response. So the large cysts, I would argue, most people would argue, I think would be resectable. A endometrioma 1 or 2 centimeters only, you would probably leave alone and run the IVF because it's not going to get in the way. And the cutoff at the moment seems to be 5 centimeters. So the work of Professor Samigliani from Italy and others, 5 centimeters seems to be the lower limit that they would say, yes, definitely resect. And then something that's 3 or 4 centimeters is equivocal, and it depends on what the patient would like and her partner and the skills of the surgeon, as I say. And then some people are more confident with the IVF egg collection than they are with the surgery.
So anything more than 5 centimeters you would suggest a surgery, the first line.
Do you agree?
Yes,
because all the viewers that our panelists and experts are advising that anything more than 5 centimeter, we should look at the surgical approach.
It not only makes the oocyte retrieval difficult, but it will also make your embryo transfer also as much difficult if there are large cysts. Yes. So I think for both reasons, it should be excised.
Sir, there is a question coming up that you said that it's worth giving a trial of IUI, at least 3 cycles of IUI that we could opt for a patient. The question coming up like, is it same for mild, moderate, severe endometriosis, or do you recommend that for severe endometriosis, the patient should directly go for an IVF?
Again, they're very good questions. And from my point of view, it's important before most IUI to check tubal patency. And in many cases with severe endometriosis, there will be tubal blockage as part of the problem. So those patients are not suitable for IUI. But if they have had the surgical resection of severe endometriosis and then go on to IUI, there's an American study from Professor Tumman that shows there is some benefit from IUI over timed intercourse in that group. Yes. IVF has a high success rate. We've already discussed if you vitrify embryos, you have a very good chance cumulatively over several transfers of having a child. So if the woman is older, and in my book that means over 30, I would probably, if she's willing, go straight to IVF. Yeah. Or if there's a desire for more than one child, because if she wants a family of 3 or 4 children and she starts at age 30, by the time she's on baby number 4, probably she'll be up to age 40, and the risk of abnormality because of aneuploidy in the embryo and so forth is high. So doing an IVF allows you to freeze embryos, and so she can have children later with a younger embryo. So you have to weigh all that up. And again, it's to be done in discussion with the couple and often with the primary care doctor and the counselor. And they know where they want to go quite often. And so many of them will have a preference. But what I think is important, and again, I'm looking at my colleagues on the screen, I do believe that NICE are wrong and that we should not rule out IUI as a cost-effective, simple approach that many specialists can do who are not skilled enough to run IVF or major surgery. but it's about accessibility. And many people can have a very good quality IUI program and refer on to the next level of specialist if it's not working.
I fully agree on that point, especially in our country where accessibility is a problem, where finance is an issue. I think IUI is there to stay, and I think it has a huge, huge benefit in such patients too.
Any addition from you, ma'am?
No, I think the message is very clear. Thank
Just
you.
to add one thing, and again, I value your comments because I've visited India 6-7 times in my life, and I spent some time there. What I think is not wise is when women have many, many cycles of IUI, because the cumulative pregnancy rate is very clear that if you run more than 3 well-performed cycles, the pregnancy rate after that is not high. And if you go beyond 6, it's even lower. So it's a shame if a woman is getting older and older in the center that IUI. Obviously, if she cannot afford or cannot access an IVF, that's different. But don't let people hold on to their patients for too long. Move on the ones that are not being successful. Plenty of others will have pregnancy with you and be happy. So it's about collaboration, isn't it?
True, true.
And right message. I think you have to limit. I think the message which we need to give out to our viewers is you need to limit the number of IUIs which you do in your patients with endometriosis.
24 IUIs.
Ideally 3, never more than 5. I think that was the teaching. And don't hesitate to refer the patient to an IVF cycle, to an IVF specialist, and better do it in the right time.
I think there's one more question coming up, sir. Like, once we down-regulate the patient for 3 months, what is the next protocol for ovarian stimulation that you advise? I mean, what is an ideal once down-regulated? Yeah.
Well, I think it's important to use slightly higher doses of gonadotrophins after the long down regulation because the ovary has been very suppressed. So with many of these patients with endometriosis, they have a fairly low AMH. So the risk of ovarian hyperstimulation is very small. So in our own practice, we generally use either 225 or 300 units a day of a drug like Menopur, which contains both FSH and LH activity. Or you could use a recombinant FSH plus Luveris, which is recombinant LH, but that's often more costly. And there are quite a few biosimilars around urinary gonadotrophins like Menopur that have both LH and FSH. I think it is an indication to have some LH activity around in that group because they've been so profoundly downregulated.
Yeah, thank you so much, sir. Let me just quickly have a look. Is there any more? Yeah, I think the questions are there, but most of them have been addressed in your lecture as well as by the comment by the panelist. So I would like to thank you, sir, for this wonderful lecture and a very nice interaction. Thank you, Dr. Shanta Kumari, Dr. Amit Patki for joining us. And thank you all the viewers for watching us on this special webinar on endometriosis and infertility. And this webinar is brought to you by Pharma, a division of MQ Pharmaceuticals Limited, makers of Dynod, that is Dynogist. And stay tuned, and we'll come back to you once again with the next webinar in the coming month, that is November. We have 2 webinars on 23rd November with Dr. Ajay Rani on stress urinary incontinence, and on 24th November by Dr. Ajay Gudi on ovulation induction. So thank you so much for joining. Thanks, Professor William Leger. Thank you so much for joining
Not
us.
at all. You're very welcome. It's been very rewarding. Thank you for setting it up.
Thank you very much, and nice seeing you, Prof. Thank you, Shanta. Bye.
Thank you.
Thank you, all the viewers. Thank you so much. Thank you, Amit, who is our technical partner for joining this on